Well, good afternoon, everybody, and welcome back, or if it's your first time, welcome for the first time to our Clinical Conversations program. We are really pleased to have a really worthwhile session that we're excited about for today, which I will tell you about. But first and foremost, this is obviously the MCHAT Clinical Conversations, and it's our regular third Tuesday of the month at 12:15. My name is Barry Sarvet, and I'm the statewide medical director for MCHAT. And the topic for today is screening toddlers for autism in general pediatrics office, pitfalls and opportunities. Before we get started, just a few housekeeping issues. So we record these sessions, and so they're available if you get distracted or if you have to step away. You can go and get them on the MCHAT website at www.mchat.com, and please tell your colleagues if they weren't able to make it that they can access it, particularly if you find it to be a useful session. The copy of the slides is available on the MCHAT website, or will be available at the Toolkits and Resources page under PowerPoint presentations. So you don't have to write anything down from the slides. Our presenters will stop for questions. Actually, no. What we decided was that that our presenters are happy to take questions, throughout the presentation and be interrupted with those questions, and they may ask us to hold them for later if depending upon the question. But please use the question function in the Zoom, and so when you type them in, we're going to monitor them, and then I will interrupt the presenters with these questions, kind of cautiously. And if you would prefer to ask yourself, just say in the question box that you'd like to be unmuted, and then we can unmute you to ask it yourself. At the end, you'll receive a brief survey, and we really would appreciate your feedback to help us improve the presentations. So just a few words about our speakers. The first speaker is actually they're really a duo, so they're going to be presenting together. It's Dr. Erik von Hahn and Dr. Chaz Hannum. Dr. von Hahn is a board-certified general pediatrician and a board-certified developmental behavioral pediatrician with a special interest in autism. He also completed a fellowship and is board eligible in child and adolescent psychiatry. He works at Tufts Medical Center and the Floating Hospital for Children. He is bringing his expertise to the MCHAT Eastern Massachusetts team and has a lot of experience consulting to local school districts and community pediatric practices, and is very interested in local capacity building for mental health services and services for developmental disabilities, and really improving the care of children with diverse developmental and psychiatric conditions. Dr. Charles or Chaz Hannum is a primary care pediatrician from Tufts Children's Hospital. He attended SUNY at Geneseo and has an undergraduate degree in biology. He went to SUNY Upstate for his medical training, his medical education. And then since he came to Boston, he did his pediatrics residency and was chief resident at the Tufts Medical Center and the Floating Hospital. And again, he is a primary care pediatrician with a special interest in autism spectrum disorders. So I will hand it over to Dr. von Hahn and Dr. Hannum. Thank you.
Thank you so much, Barry. I'm glad to be included in the conversation. We had a bit of a discussion about what would be the best topic to cover when you're talking about autism, and we settled on the screening of toddlers and the pitfalls of screening of toddlers. And we're hoping that's going to be an interesting topic for everyone who's participating in the seminar today. If we do go further afield, that's great. but we're hoping we're going to be able to answer your questions about young children and screening practices. Jazz, do you want to say a word of introduction? Or?
Yeah, so I just really briefly, so so I'm a general pediatrician. I'm fairly young attending. This is my, if you include my chief year, my 5th year being kind of in primary practice. And I say I have a really large population of kids who are 5 and under on my patient panel. So I deal with this all the time, and I've had to try to figure out some creative solutions for early diagnosis and trying to figure out how we can get services for kids, and working closely with what we can do from a clinic standpoint, understanding resources, and how we can also utilize early intervention in schools to also be an ear and a sounding board for us as we think about these issues.
Yeah. Remember your community partners, very important. Next slide. So this is an outline, we'll look at the next slide. An outline of the discussion today. We've gone through the introduction. We're going to talk a little bit about what's the issue with screening of ASD. Probably all of you already know that. We came across an interesting population-based study on screening, which we're going to share, which highlights some of the problems. We'll talk about the MCHAT, which is kind of the mainstay of screening, although it's not the only way to screen. We're going to talk about the hub model, if there's time. Yet another article that we ran across that we thought was interesting, which is kind of what one could call a level 2 screening process or diagnostic process for autism. That's available, I think, in the state of Utah, just as an interesting model. And then we'll talk about how some of the ideas from the hub model could be integrated into a general pediatrician's practice locally, and leave it open for discussion. There's lots of different ways that we can take the conversation. Why don't you go to the next slide? So even for a seasoned clinician like myself, who sees a lot of children with autism and who also sees a lot of young children with autism, it's not always obvious. The autism isn't always obvious, and I think it's less obvious in the primary care setting. There are a lot of children with autism that can follow your instructions very well, and you're not going to notice that they have autism until you start to dig into some of their social and communication behaviors more deeply. Right now, the pattern appears to be that the diagnosis is happening around the ages of 4 to 5. And as a field, we don't think that's really quite good enough. We're really seeking to make the diagnosis earlier. I'll be honest, I work in Eastern Massachusetts, I work in Boston, and I tend to kind of raise an eyebrow when I see a new patient evaluation for autism when the child's already above the age of 3. So my experience is that the screening is working well. But I do have kids that get diagnosed around age 4 to 5. Nationally, that seems to be more commonly the case. And the issue with a delay in diagnosis, especially those 1 or 2 years of delay when a child is still so young, is that we're losing out on the therapeutic opportunities while their brain is growing so rapidly. So we feel there's some urgency to getting the screening and the diagnosis done more quickly, more accurately, and to get the diagnosis done sooner. Do you want to add to that, Chas? Should we just go next slide?
I think this really comes down to also motivation from the family, and from my experiences. I think if families are more worried about development or have some additional perspective that can make them more on board with paying attention to things, especially this, I would say over the last year with coronavirus, I've got a lot of skepticism, even just the utility of a referral to early intervention. So I think that, a family who is interested in your advice and is willing to do it is certainly a really important and probably one of the most important tools when thinking about early diagnosis. And go ahead, Erik.
No, I like what you're saying, because in my conversations with general pediatricians, what's come up more than once is, well, what do I do if the family doesn't want to go to EI? And my response is, great question, because that never happens to me, right? They come to me because they want my services.
Right.
And I think it's not only the access to services that gets affected by the parent mindset, but it's also the awareness that gets affected. And the ability to describe child behaviors is different depending on how tuned in you are to your child's development. So the history changes based on how the parents are perceiving the concern about autism or the concern about child development in general. I think it's a really interesting wrinkle in the problem of screening. Next slide.
One thing I will add to that, I think, is I've realized that through you doing developmental screens with families for well visits, that when there is a concern of a language delay, those are definitely parents who are maybe a little bit more in tune of what does that mean. And I would say almost always I try to ask the follow-up, what have you looked up online related to, being concerned that your child does not have language skills? And I would say 99% of the time that they've know that autism is on the list. So I think part of that role that we play as primary care physicians is letting them know that, yes, that's on my list too. And that's why some of this evaluation and additional workup, there is a little bit of an urgency because we can intervene if the diagnosis is true. And I find that does motivate families pretty nicely.
That's good insight. This is a picture of the list of questions on the MCHAT for those who might not be familiar. We can get into the specific questions as part of our conversation if the group finds that interesting. I think there's some concepts around autism that are good to know when you're using the MCHAT. Probably would increase the person who's doing the scoring, would increase their ability to ask the right questions the right way. But let's skip over to the next slide. And we're going to...
Erik, just
a
quick question from the chat. And you may want to answer this a little bit later, but the question's from Barbara Sisson, and it's about sort of the fact that EI is completely virtual during the pandemic, and sort of noting that, of course, autistic children often have trouble with engaging with the computer, and so that might be something to keep in mind, for some later discussion. But if you have any thoughts about that now, you can share that.
Yeah, so the 10-second answer is the EI has to move to a consultative model that trains the parents to work with the kids. And be sure to bring that question up again towards the end of the talk for the discussion, because there's specific examples I can share about what that would look like and why it's so important, actually.
Thank you.
Good question. Yeah. So we're going to set up our questions now, right, Beth? We're going to ask the group, how many of you do the MCHAT as a part of your care? We're really curious to know, what are your current practices? And be honest, we all know what you're supposed to do, but what is realistic and what's feasible? We're going to give you 30 seconds to answer these 4 questions.
Responses are still coming in, so I think we'll give it a few more seconds.
All right. Oh, these are nice results. So How often do you complete an autism screening using the MCHAT? Almost always. We've got 81%, and a few that are maybe not able to do it as consistently. How often do you complete the MCHAT? Twice. Now we're down to 50%. So that's an interesting piece of information for us to think about. Can you scroll down further, Beth? I'm not able to see the other answers. Or was Barry going to review this with us? I've forgotten what we decided.
I can review it. Actually, you scroll yourself because it's not the screen share.
Okay.
Sort of pops up. But in any case, the third question is what specialists do you usually refer to for clarifying or making diagnosis of autism? And 86% say developmental behavioral pediatricians.
Okay.
33% child neurologists and 19% psychologists. And the fourth question is, how long does it take to obtain a diagnosis from a specialist after you refer? And none in less than 3 months, 33% 3 to 6 months, 29% 6 to 9 months, 29% 9 to 12 months, and then 10% greater than 12 months.
Sure.
It can be a long time. Yeah.
So that's kind of what we always perceive as being the biggest barrier, is just access to the diagnostician. And I think the numbers there really bear that out. That's great. That's not great news, but it's great to get that information and that feedback. I'm glad that some of the kids are getting their diagnosis within 3 months. That's not the rule, unfortunately.
So there's a couple of questions about people with, about children from bilingual families, and ethnic and racial differences in children, and whether or not there are different kinds of diagnostic challenges with those patients. So the first question is I wonder if there's any data about ethnic or racial differences in children who present at later ages before diagnosis. I think that's to your point before about people really identifying most of these children early. And then there is a couple of questions about whether or not the MCHAT is available in Spanish and what the access issues are for bilingual families.
I have my own opinion. I don't have any data at all from this, and there are some issues around bilingualism, especially when you're conducting the test in English and the kid doesn't speak English particularly well yet, or perhaps not at all. It is harder to make the diagnosis in children who haven't developed English language proficiency. And I think there are also cultural norms embedded in the questions and how we ask them. We Americans look at kids in a different way than other cultures might do. And the questions that we ask might feel foreign or just be confusing to people from other cultures. So you're going to have to give a lot more behavioral examples of what you're looking for when you're working with someone from a different culture, plus or minus, who doesn't speak English as well as you do. What's your take on that, Jess? What do you think?
Yeah, so there are translated versions of the MCHAT, at least from a screening perspective, so you can rely on that. I think the barriers that I find, we have a fairly decent percentage of non-English speakers from lots of different languages, and I think the most important thing is that if you don't have that easy to access, that's the big barrier, is time. And so I think if you're worried about a child after you get to some type of developmental history, whether you have a developmental screen that's helping your history gathering or not, I think that those conversations can take a long time, especially if you're using a translator to speak with the family and better understand what the profile of the child is. So I find the follow-up visit, and this is where, if your MCHAT is even just a, kind of a little bit positive for a family that you may be a little skeptical on, how well they may be understanding the questions, I think it's really valuable to, do some type of follow-up, whether that's a formal in-person follow-up so you can have more time to observe the behavior, whether that's a telehealth visit. Now that's, I think, easier for most people, but I think that gives a great glimpse at what the child is like in their native environment. And then again, just taking the time to really, spend 20 or 30 minutes talking about this, because I think that's the biggest barrier for me is time when, either it's a language barrier or just, the family maybe has intellectual disability and doesn't understand the questions or the screens. So it's something that you can't really find, or I find that it's not easy to address in the setting of a well visit when you're already feeling rushed, probably.
Yeah. So this is why we felt it was so important to include Chaz in the conversation. Full disclosure, I don't use the MCHAT for very obvious reasons. I'm the diagnostician, so I'm not the person doing the screening, and the issues are different. One thing I will say though, this dovetails with the issue that we're going to come up with later, is the level 2 screener. There's a thing called a level 2 screener that you can also consider integrating into your practice for those cases where you're not sure. We'll talk more about that later. We're ready for the next slide, I think. So this is a study that we came across that we thought was interesting because it highlights the issue of the problem of early diagnosis. And in fact, what this study highlights is the low sensitivity of the MCHAT as compared to research settings. And I think everything we've said so far about the clarity of the questions and whether the parents understand them and how much time you can spend making your own observations, all of those things really reduce or increase the sensitivity of the MCHAT depending on how much time you can dedicate to them. Next slide. So in this particular study, we have a huge population of 36,233 toddlers. This is all a medical records-based study. And the charts or the records were reviewed for evidence of screening and how that later panned out to a diagnosis of ASD. So they were checking how many kids were screened, how many screen positive, how many screen negative, and then how many of them ended up having a diagnosis of autism and at what age. So we're going to take a look at the results. Next slide. So out of the 36,000 children, 522 were diagnosed with autism at the time that the data was pulled, which I think was like 5 years later. And that results in a prevalence of 1.4%. So that's pretty consistent with what the literature is telling us. The age at diagnosis, very high, 4.75 years to 9 years, okay? For me, that's very high, and this is a study this study was done in another state, but I've forgotten which state it is. For me, this is late. I think in Massachusetts, we're doing better than this, and be interesting to know what the reasons are. But there's a lot of kids being screened that are being diagnosed late, and there's a lot of kids that are not being screened who are not surprisingly being diagnosed even later. Next slide. So in this study, the rate of screening was in the 70% range. So, not horrible, but could be better. Interestingly, the number of kids who, the total population that were screened is the same as the number of kids who ended up having ESD, so that was consistent. We're talking here about a screen at either 18 or 24 months. So one screen is always going to be less sensitive than two. That's good to know. Next slide. Kids who screen positive were diagnosed earlier, so that's good to know, 38 months on average, so just over 3 years. The kids who were screening negative were diagnosed later, so closer to 4 years, right? And it's interesting to think about, why do kids who screen negative end up getting a diagnosis? Why do they get referred? And I'm not sure what the answer is. The study didn't address that question. But looking at the numbers, and I did understand how they crunched all the numbers, and now I can't replicate how they did this, but they came up with a sensitivity in the 33% range and a positive predictive value of 17, which is of course shockingly low, and surprising because the psychometric properties of the MCHAT are much better than that. And so my sense is that has a lot to do with the conditions under which the MCHAT is performed, but perhaps also how often it's performed in that population. I don't know, Chaz, you want to chime in here for a moment? Or?
Yeah, I'm happy to. I think, again, back to what I was saying before, I think for younger children, it's really more about getting a comprehensive picture. I think everybody has a different threshold for how they use autism screens and then what the next step is. So obviously, I think the luxury of using an MCHAT or an autism-specific screener is that you're usually doing it younger, where you can refer to early intervention. And I think to a point earlier, early intervention, even though they're virtual, I think it is at least probably the quickest opportunity potentially that somebody will be talking in depth about that child's development. And again, I think even though the children may not be able to cooperate well, I think having that defined time and having the perspective of at least 2 different people from early intervention, understanding what the child is doing, I think gives a really nice clinical perspective to me, when maybe I don't have the urgency, to see the patient in a month, or the family maybe doesn't want to come back and see me because of coronavirus, and they'd rather do something, via telehealth with early intervention. So I do think that, the more comprehensive view you can get is going to be better at contributing to the sensitivity of making the diagnosis using the MCHAT plus other things. So that's how I at least interpret from my own clinical practice, why the sensitivity is so low and why the screen negative children end up getting diagnosed so much later, is that, your observations are going to be limited in the room with stranger anxiety. It's just a quote unquote shy child, where, subjectively the parents don't necessarily know what we're looking for. And so, obviously that gives some bias to how we use the screens, but I think if you see an MCHAT, you may kind of gloss over some of the developmental stuff and not be worried that you have a kid who's, crying the whole time and assuming it's stranger anxiety, when in fact, maybe it actually is some type of abnormal social interaction that, has yet to be teased out. I could go on and on about that, but I do want to comment briefly on the SWIC. Somebody in the questions had asked that they use the SWIC and then they use the MCHAT if possible. So the SWIC is the Survey of Well-Being of Young Children. It's a developmental screen that was developed here at Tufts. It's been around for a decent amount of time, I think maybe 5 to 10 years or so. We have used this in the last, I think, 2 years now as our primary developmental screen versus all the different things that exist out there for our kids 6 and under. And why I like that piece is because it gives you different glimpses into the child's development. Now the MCHAT, 20 questions, that's a lot of questions for a family to answer, in the moment, in the room. Maybe they're showing up 10 minutes late to their appointment. I work at Tufts here in Chinatown, so everyone is always showing up late. So I think a big barrier, again, is time. But when they can complete the SWIC, there's a section on milestones, there's a section on behavior, and then for the 18 and the 24-month kind of developmental screens, there's also what's called the POSI, which is the Parent Observations of Social Interactions, which is really the specific autism screener for that age group. So I find it very interesting when I have a kid who has beautiful milestones, but the POSI is very abnormal. And there's some clear behavior issues with, transition difficulties or sleeping challenges. And I think it allows me to at least get a better glimpse and kind of focus my history so that maybe I can address it more smoothly or more efficiently in terms of what the follow-up may be. Because I think, between a well-visit schedule, 18 months, and then coming back in 6 months for 24 months, there may be a really, critical piece of development that you're not necessarily, seeing. So I do think that having more information makes your ability to assess and then decide, do I need to refer this person earlier, a little bit easier to make, because it can be challenging.
Yeah.
And also, I think more importantly, you can help convince the family that this is truly, something that is abnormal. So I think it's, again, there's a lot of subjectivity to these screens. That's never going to go away. But I think taking the time to acknowledge what's abnormal and then really seeing, is that truly abnormal, compared to your own observations, I think that provides a lot of oomph to your assessment.
Cool. Yeah, I'm a big fan of the POSI. We have it embedded in our own intake package, and I find it's really accurate. Next slide. So these are some, actually, this was we've covered some of the questions here. So why do some kids not get screened? Why do some not get screened twice? Why do some who screen negative end up having ASD? And then what promotes or what prompts a pediatrician to send a screen negative child for a diagnostic eval? What do you think, Chaz? Have we covered those questions, or do we leave this open for the chat a little bit?
Yeah, maybe we should leave it over. There's a couple chats already coming in. I think that might be.
Go ahead. Let's see what.
That way.
Spell the screening tool that you use. SWIC. SWIC is SWIC.
To Barry, yeah.
Barry's going to take care of it. Okay.
Yeah, and then POSI is POSI.
Right.
If you just search Tufts SWIC, it's really easy to find the website. And why we moved to this developmental screen is that it's free. Compared to other developmental screens that you may use in your own practices, this one is free and you can use as much as you need to. And maybe I'll comment on Jen's question about the best workflow. So this is I would say, again, it comes down to time. This is the biggest problem for me in my practice. I also am one of the program directors for our residency program. I run our continuity clinics for them as well, and I supervise in clinic. And I find that navigating this with residents is really challenging, again, from that time perspective. And I think when you have a patient who shows up late to their appointment and you still will see them, you're never going to get that developmental screen as you're trying to get your assessment. So sometimes it's worth the 5 minutes to say, hey, fill this out before I come and see you, because maybe you have your suspicions high, a little bit from their last well visit, for an example. I think ideally, and then fully integrated EMR, you send this to the family first before their visit, the day before. You have that information as you're preparing for your visit. We don't have a system that allows us to do that. So everything for us is on paper. So they check into the front desk, they get the developmental screen, they complete that. And I find that is, helpful for making sure that it's done. But there are families where if I'm, I may be really reassured at an 18-month visit because the kid is interacting great with me. I see joint attention. I see, some nice parenting skills. If I don't have any concerns, I may not, force the family to do the entire developmental screen. But if I am worried enough, I will say, I want you to do this while the nurse comes in and gets your vaccines ready, or, give this to the front desk. And I think that definitely helps me when I'm feeling a little uncertain about just a history and my observations in the room of, again, using what I can. Because I think it's really hard to make that, unilateral decision to say, should I refer or should I not refer for more of a diagnosis piece?
So there is a question about wait times for evaluation, and as we saw in the poll, people wait a long time to get patients their, full, assessment. And so the Katie McBride wondered if we use a screen, is that something that would get them in sooner? Do you have thoughts about that?
Yes. So probably the answer is yes. We used to be much better at bringing the young kids in quickly, and we always prioritized them, and we were very good about seeing young kids within about 3 or 4 months. And that's really changed. We've lost some staff FTE. I think the numbers are getting higher. Right now with COVID, the number of patients that are getting through the clinic is a bit lower than average. So all of those things are really slowing down the train here, and young kids are getting diagnosed much later than before, and it's a big source of concern for us. But just as a personal practice pattern, what I do, if a pediatrician calls me and says they're worried, I just put the kid next available new patient slot, just as an automatic. And I think that that's something you should feel like you should be free to do. There are certain kids where you might be more willing to wait. Hard to say if the ones that are the more impaired need the services more badly than the ones who are less impaired. That is really not an easy thing to say, but I think based on your own level of suspicion and your worries, I think you should go ahead and call. And yeah, do a screen first. Do 2 screens. Other comments or questions about?
There's one question, Eric, that says, I'm curious about your use of abnormal, in quotes, instead of atypical or not typical, if a child is, having some developmental problems. And I guess I can address that. I try not to use atypical. I would like to, but I don't think parents understand what that means as much as abnormal. And I've been pretty candid with families and have asked, like, what have you Google searched about your child? And usually, they will understand that something is abnormal. They don't know what necessarily it might be or what that means. But I do use abnormal in terms of whatever their observations happen to be. And I try to put it in the perspective of what they've witnessed, if that is possible, because I think it just gives a better framework for then how you will address what the abnormal problem is, so to speak. Mm-hmm. But obviously that's a complicated question too, because some things are abnormal at certain ages, but normal at other ages. And so I think it requires a little bit more of a conversation. But I typically will use that, I'm worried about your child's motor skills, and I think they are abnormal because of X, Y, or Z. Or I'm worried about your social or language skills because this is what I expect them to do. And so they're not doing what a normal, developing child or what I would expect them to do. So I try to phrase it that way. I think that, again, keeps it efficient for me, but also make sure that they're on the same page. Because I would say maybe early in my practice, I've realized that if you're not being super transparent and really labeling things, that you have to very much so make sure the parents understand what your concerns are. So if you don't say it, essentially, my rule is they haven't heard it. And so I really try my best to be as explicit as I can in terms of the concerns that are presenting.
Yeah, no, that's nice. A nice summary, Chaz. I use the not expected at this age. That's a really good phrase to talk about. And then also frequency and duration of behaviors. It really helps to make that distinction between what's clinically significant and what's clinically not significant. So I use those a lot. Not expected for age, and then how frequently or how much of an impact is this behavior having. Okay, let's go to the next slide. Now, there are a lot of people are thinking about this problem because it's really a national and an international problem. There aren't enough developmental behavioral pediatricians or other specialists who can do the kind of diagnostic work that we do. And it can be done by others. We just haven't set up the systems yet to do that. What one study that we looked at showed is just how can you do supplemental testing in the primary care office, because there just aren't enough providers who work with young kids that can sort out these issues. So let's look at the next slide. So there's I don't know what EAE, early identification of autism, I think it's something along those lines. There's a hub model in Indiana where that's good for the state. And again, you're referring out to a center which was set up, a specialty center that was set up to take care of this, quote, backlog of positive screening or at-risk children. Now, we don't have that in Massachusetts, but some of the principles are interesting because they could be incorporated into a general pediatrician office. So what the model offers is they review the ages and stages questionnaire, they review the MCHAT, they do a diagnostic interview. So that goes back to what Chaz was saying about spending more time describing what the behaviors are, the behaviors of interest, and helping the family understand what those behaviors are. Doing a physical exam, which any pediatrician can do, but then administration of a level 2 screener. And I think that concept of a level 2 screener is useful because it's probably going to end up in the general pediatrician's office. The one that they used is the STAT. And if we go to the next slide, I think, no, I didn't go there. There's two that I'm aware of. One of them is the RITA-T. I'll explain what the acronyms are in a couple of slides down the road. And the other one is the STAT. So these are not diagnostic tools. These are level 2 screeners, but coupled with the DSM interview and coupled with the other information gathering procedures, they're pretty confident in making an accurate diagnosis of autism. Let's look at the next slide.
One thing I want to add, Erik, real quick, is
Yeah.
just, I think, related to, that kind of next level step. This is where I think if you identify a concern early enough and can use early intervention as a powerful tool for not just initial assessment, but ongoing evaluation and assessment, I would say the times that I have had early intervention reach out to me and say, hey, we're kind of worried this child has autism. Here's a screen that we did. And here's some problems that we're identifying. I think that really, I would say probably with 100% sensitivity, usually that child has autism, at least in my experience. So I think when you have the ability to involve early intervention, I think that that can really be a powerful tool for you. Again, especially in that, 18 to 24 month range or 24 to 30 month range, where you may not be seeing families as predictably, especially if it's a subtle delay and you're not sure, maybe this could be autism, but it doesn't seem like it at that point. They can be really helpful eyes and ears to just speed the process along, and may prompt you to refer earlier versus not.
Those are great points. So that there's a DSM diagnostic interview that you can conduct to enhance the value of your screen, more detailed behavioral observations. One thing, and I do it quite commonly in my follow-up visits, because I also have to check up on my own diagnostic decision as I follow the children. And one of the things that I really enjoy doing is a narrative task. There's a book that we use called Goodnight Gorilla, which is part of the autism testing kit. So I wouldn't want you to use that one, but it's an example of a book where a kid has to look at some pictures and try to figure out what the storyline is. It's a great example to set up an interaction. It's good modeling for the parents. It really fits in with your Reach Out and Read program. And it gives you a chance to see how the child responds to a natural activity. So that's one thing you could do. The CARS is the Childhood Autism Rating Scale. And I don't know if it's free, but we use it quite commonly. It's a fairly detailed questionnaire with observations that you make yourself. So you as the clinician observe the child, and you also ask the parents, does this behavior occur commonly, or have you noticed this at home? And jointly you decide on how to score it. It's a nice tool to use. We use it diagnostically, but it could potentially have a role to play in the general pediatrician's office. And then there are these level 2 screeners. They're called interactive screening instruments. And one of them is the RITA-T, which is an open source one. It was developed at UMass in Massachusetts. That one's definitely worth looking at. There's 8 tasks on it. I think it takes 10 or 15 minutes to administer. The CARS takes me probably about 10 or 15 minutes to do. Next slide. So those are the 2 level 2 screeners. I'm not familiar with the stat, except from the study that we were just discussing. I am familiar with the RITA-T. And again, we don't use screeners in our diagnostic clinic, but it is one way to really enhance the sensitivity of whatever screening procedures you're using in your office. So I think there's, Chaz, I'll let you jump in, and I think there's some questions.
Yeah, sure. So I actually have had experience with using the CARS test, and I think it's in the second version now, so it's CARS 2, and it is a diagnostic evaluation tool that you can use as a PCP. It is a little confusing to understand, so I was kind of recognizing the issue of just delay and referral, especially I refer to our own group, which Erik is in, and there's a lot of complicated patients that come through their clinic. And so, for me, when I have an early intervention program that's saying, hey, we think this child has autism, my clinical suspicions are pretty high already, outside of that evaluation. I have done the CARS 2 a couple of times and have been able to make the diagnosis of autism combined with my, evaluation, speaking with the family. Knowing the patient, I think, is really important, though, if you're using this tool. But you can write a letter, you can provide the testing outcomes, and it will qualify that patient for ABA services. Now, for all the children that I've been able to do that, it's really so that we can get services. And it doesn't really, I would say, negate the need for an evaluation by a developmental behavioral pediatrician or whoever you tend to refer to, because I think from a family support system and from a long-term follow-up as school is approaching, I think that is really helpful for families to have. And then also it can give a little bit of more diagnostic clarity if there's anything else, such as intellectual disability. So it can be useful. I have used it. Again, it's a little bit of a challenging tool to get familiar with, but it is helpful, and you as a primary care pediatrician are able to do that, and it, qualifies. Both of these patients had mass health, so it is it is a, I can't remember the category they use, but it fits the qualifications, so to speak.
So a couple of questions in the question function are about sort of how to get services started, really, in the absence of a specialized, assessment. And so one question is it possible to get ABA services started based on a screen like the MCHAT or the POSI? And then there also is a question about, and I know that you can refer to EI, without a full developmental assessment. But the question is, what's been your experience in terms of getting feedback from EI providers, especially, if the EI is limited to a virtual format?
Yeah, I'll answer the last question first. I think definitely I've noticed that the feedback is not as great as it used to be. They're not doing the Patel, at least from the early intervention groups that I've used. They're using, I can't remember what it is. It's definitely, I don't think, as helpful, but it still will give a nice narrative for all the developmental domains. And so I do think when I get it, it's helpful. And this is all a matter of, who is referring, so that you can make sure that you're getting the report. All early intervention programs are not created equal in terms of their follow-up with you as the pediatrician. So I encourage families to try it, if there's a release that needs to be signed so that I can talk to EI. I try to plant that seed pretty early when I'm telling them about the referral. And depending on my level of follow through of how I think the family will do, sometimes my office will refer, sometimes I'll have the families do it. I think it depends on your relationship with the family and what you plan for follow up. And then to the first question about ABA services based off of a screener. So unfortunately, it will not qualify. And so this is where, as a PCP, the CARS 2 tests, that's one of the few things that you can do if you feel comfortable. And again, I've really only used it when I am willing to bet a lot of money that this child has autism. So it's already when I have a very abnormal MCHAT or I have a very abnormal POSI, and my observations in the room, it's a child that is hard to engage, has some stereotyped behaviors, no joint attention, no social real skills. So I find it's definitely situational and when I use it, but those are the children in my mind that probably need the services as fast as we can get them. And so, but again, the times that I've used the CARS 2, those have been at a pretty high severe level of autism. And again, I felt comfortable making that clinical diagnosis just based off of the DSM-5 criteria before doing the test, but you need the test to be able to get the ABA services.
But I like what you're saying, Chaz, because it's the more obvious cases that help you learn how to use the CARS.
Exactly.
And so it's a great learning opportunity. So for when you have a kid that you're concerned about, that's a great solution. But the insurance companies are specific about this. There's a specific set of tests that they accept as diagnostic. And thankfully the CARS is one of them. But the other ones, the screeners, are not. So. And then I have my own experience with early intervention as well. I think you should absolutely reach out to early intervention. I think they actually really appreciate it. They realize that you value their input and you're curious about what they have to say. And I think to foster and further that relationship and that acknowledgement is always worth investing in for all of the kids. Were there other questions, Barry, or?
Yeah, there's a question from Barbara Sisson, expressing a need for more of a definitive answer to the question about sort of whether the use of EI as a consultative model, particularly during the pandemic.
Sure. So I don't know, using a therapist in a consultative model is a very well established and very it's a high quality service. It's really associated with strong effect sizes. And I think I know this specifically from speech language pathology, that a consultative model where the speech pathologist does not work directly with the child, but works with the parents, has a very significant positive impact on the child's speech language skills. And it makes sense when you think about it. Parents are with the kids many more hours per day than any therapist. And you can do 1 minute of speech language therapy in the bath and 2 minutes of speech language therapy for your bedtime routine. You can fit it in all sorts of nooks and crannies of the day. And so that's the model that I advertise and that I try to celebrate with the early intervention teams and also with the in-home ABA providers, the ones that are already taking care of my kids. I think maybe some of those providers are trained in a sort of a specific mindset that I work with the child and they haven't been taught how to do a consultative model. The challenge is, how do you describe what you know as a professional and help someone else apply it in a meaningful way? And I think that's something that a pediatrician is very comfortable doing for all sorts of different kinds of interventions that we ask parents to perform for us, for their kids. But it's not clear that other providers have that same experience. My experience, though, is that when you tell them that's an option, they're actually quite interested to do it. They'd like to help out, and they just haven't really thought it through. So I would just really encourage you to talk about a consultative model. What are the things that you could teach this family to do? Every week, check and see if they were able to do it and if it made sense, et cetera. And then there's some very predictable things that parents need to do for kids. They need to have a schedule, for example. They need to speak more slowly. They might need to repeat. They might need to show before they talk. I mean, there's very, very simple things that a lot of families wouldn't do. And in fact, a lot of families with a child with a disability would be very timid about doing because they think they have to do something very different because their child is developing atypically. And a lot of the common sense things that you might do for a 2-year-old or a 3-year-old, they more quickly go out the window when your child has a disability because it's harder to see the positive impact. And I think a consultant like early intervention, just reinforcing those really good parenting strategies and the schedule and the clear communication and the visual communication, those are really worthwhile pieces to include in any kind of a consultation. And that might be worth sharing with whoever you talk to. Hope that wasn't a long-winded an answer, but.
I just wanted to piggyback because someone also asked just other specific services that you see doing well via telehealth. I would say I try to phrase it almost in that mindset of what Erik was referring to, where early intervention is really here to teach you as a parent what you can do, right? 30 minutes of speech therapy a week is not going to drastically change a child's language trajectory. It's about taking what they learn and implementing that into their regular parenting skills and styles and kind of the daily routine for their child. So I now definitely phrase things more as they're going to help you understand how we can, address this, abnormal development or how we can work on language skills. And so they're going to be able to have more time than I have. And I kind of pitch it as like, this is an opportunity for you to really get a pretty comprehensive look at development from that initial intake. And then again, depending on what the concerns are, I think it's just that focused time. That some parents are like, yeah, I want everything. I mean, kids who qualify for early intervention from like a NICU stay, those parents, I think, understand the utility of having that help. So I try to frame it in the peace of mind of this is just somebody else who is an extra support for you to help you with whatever problems your child may need to work on. And I think that makes the virtual kind of model a little bit easier to understand. And when you have your rambunctious 2-year-old who can't sit still for more than 30 seconds in front of it, it doesn't really matter that they can't do that. It's really more about the knowledge that parents can gather. And then Keith had asked in the questions, the hub model. I can't remember from the actual thing of who's doing what and when, but what I will say is that I think now with the new E&M coding changes, that started in 2021 with, I would say because you're doing a screen, reviewing the information and spending a significant amount of time, the CARS 2 test, just to use an example, probably takes about 20 to 25 minutes of real-time assessment, which I know that I've never done it virtually, but virtual will be a definite possibility depending on how well you know the family. And again, I think there is some utility of having the child in their own native environment. But so I would say, the times that I've done it, I've been the primary person doing it. And now that we have different ways to, bill for a higher level of service, I think this is clearly a level 5, established patient code that you could use to be reimbursed for probably the time that you would need. But I think there's definitely opportunities for, having support staff or having, like a nurse or an MA reach out with, hey, here's some screens. Have you done these pieces of information? Because the reviewing and just assessing all of the information that you have definitely is what takes the longest. But I think it gives you some really good perspective on the patient.
Well, yeah. And the hub model is actually, it's a specialty center, but it's run by general pediatricians. So it's not run by specialists. Let's go to the next slide. Let's see what's coming up still. Okay, so we're really, I think we've covered all the major points here, and we can kind of open this up to further discussion. But the bottom line is early diagnosis matters because early treatment matters. Early treatment matters, we think, because of the plasticity in the brain. Just so that you understand what the science actually says, and I'm probably a little bit out of date, but based on on meta-analyses, the difference that early intervention makes, or early treatment of autism makes, I should say, is that statistically speaking, it reduces the number of kids who end up in special education when they're in grade 1. That's really how the literature is framing the benefits of early ABA services. It's probably much more complex than that, but that's something that you can say is sort of a scientific or evidence-based information. All of this is complicated because of the issue of diagnostic stability. So even though there are 2- and 3-year-olds that absolutely meet the criteria of autism, you know, quote, even after they've seen a specialist like me, the number of early kids who end up having diagnosis when they're 4 or 5 is not 100% of that population. It's probably 85 to 90%. So 85 to 90% of the time when you make a diagnosis of autism in a 2-year-old, it's going to be autism when they're 4 or 5. But that means that 10 or 15% of the time, it's not autism when they're 4 or 5 or 6. It's a different disability. So there is an issue of diagnostic stability that we have to look at. On the other hand, sometimes people say, well, it's because of the treatment that the autism morphed into a language impairment and is no longer autism. So those are all questions that we're not able to answer yet. Are there any questions that are coming up just from?
Yeah, there's no questions at the moment, and so we'll give them more time to type them in. But I wonder if we could talk a little bit about you know, the issue that we talked about before we started the webinar, kind of offline, as far as the overdiagnosis of autism in the older age groups. I guess it's kind of related and, you know, indirectly to the point that you made about sort of the stability of the diagnosis.
Right.
So I wonder if you could share some thoughts about that.
I'm happy to share thoughts about that. So the kids that end up being diagnosed later, very common pattern, are the kids with good language skills, plus or minus a normal IQ. So those kids are going to slip through the cracks. Those ones are going to screen negative. You're not going to notice the autism because they're too smart. But by the time they're 4 or 5, and sometimes it takes even longer, but by the time they're 4 or 5, you start to notice that they're socially atypical. The other kids are becoming more sophisticated in their social interactions and your patient isn't. So that's another example of this issue of diagnostic stability. No autism and then later does have autism sometimes has to do with the social impairment becomes more obvious as the kids get older. But the other group that Barry and the gang and I were talking about before we started our seminar with you is the kids who are diagnosed with autism when they're older, like when they're 6 or 7, and they're actually kids that have a lot of disruptive behaviors. Very commonly, they have anxiety, they have associated learning disabilities, they have associated attention deficit disorder, and they're really falling in between the diagnostic cracks, or maybe more accurately, they fall into too many diagnostic categories. And there is a very obvious trend, I think, to label those kids with autism, and some of them might have it and some of them really don't, but it's hard to tell because there's so many co-occurring conditions. So at a seminar that I attended some time ago, one of the most common reasons for saying that a child has autism when they probably don't is when they have combined attention deficit disorder and anxiety. So that's absolutely what I call an autism mimicker. And if you can really address the anxiety, you start to understand how socially capable those kids are. But in the natural setting, they really end up looking quite atypical. And another group that I think suffers from the same misunderstanding is the kids with anxiety and language impairment, same thing. But, and then a lot of the kids with disruptive behaviors, the kids with oppositional defiant disorder, or however you want to call it, disruptive behavior disorder, those often get relegated into the autism category. And those ones are tricky because some of those kids really do have social impairments. And so it's hard to make a clear-cut diagnosis. But the DSM wasn't always about clear-cut categories. So there is a murkiness to it. But the number of cases of autism does seem to be going up because of this diagnostic confusion.
So Erik Ruby is asking for some feedback about a case, particularly, or an example, which is, I'm sure, very common in primary care, of an autistic child who does not sleep, is in constant motion, and is disruptive. How do you treat?
Yeah.
So that's kind of that's a classic MCHAT question that we received. But what are your thoughts about that?
Well, yeah, it's a problem that you disentangle over time. So those cases feel incredibly alarming when they're first brought to your attention. The parents are exhausted, and the parents are themselves pretty dysregulated by the experience. And so one thing is, don't underestimate the power of your clinical interview, and just getting the family to be heard makes a big difference. The parents have to find their kind of inner core and inner strength to deal with what can be a really disruptive situation. And one potent tool for any kid, doesn't matter if they have autism or not, is that the parents are able to go about their business in a calm and confident way. And they can do that much better after they've had a good listen and a good chat with you about it. That's one reflection that I share as a general comment. The other one is, I'm always confused by the history when I hear this kind of history. And I sometimes want to take it a second time around a week later. So sometimes just sitting and listening and helping them unload their frustrations also helps them bring greater clarity to the history. I can't tell you how many times I've been told that a child doesn't sleep. They do. They do sleep. Okay, they don't always sleep at the right times. There are some really bad nights when they sleep really badly. But if you can dig in between the more normal days of the week, you discover that actually they are sleeping. And that's an important one. And then the other one about my child doesn't eat. Kids eat. Eventually they do eat. And I don't try to push that insight onto parents immediately. I think I need to let them really unload and share their frustrations and their fears before I try to get to the more underlying, well, what's kind of happening more commonly. So definitely take your time as your first step. You're going to get a much clearer picture if you sit with the family a bit longer, and if you get a bit more clarity about what's really going on most days, even though I know that yesterday was really, really horrible. And then after that, the next steps you take become more clear. You start to focus on, well, what do I really need to treat here? And treating sleep is certainly worthwhile, but treating disruptive behaviors requires a lot of scheduling, for example, and there's other more detailed strategies that we could get into. I hope that's a good start to the question. Those cases feel very overwhelming, and just make sure that you take a deep breath and see if you can make it feel a bit less overwhelming before you move forward.
Yeah, I think echo that. I think for a family that, let's say, coming in for a well visit child already has a diagnosis of autism, it's okay to, I think, let the family know, these behavior issues or whatever the problem may be might need another visit or a pretty soon follow-up. So I agree with Erik's point of just taking the time to process it, have the family really just focus on one problem can definitely give you a little bit more clarity as to what the problem may be. And that's where I think all children who I have suspicions for autism, I do think that developmental behavioral pediatricians can be really helpful for being able to be experts in teaching parents how to do some of these things that they can try to incorporate into the daily life of their child. And that's where if a child's already getting ABA services or already is in school with a really good structure, they're trying to figure out what does the school do well that the parents aren't doing well that they can learn from. And that, I think, again, depending on the problem, really helps at least provide you with some comfortability and also just more experience talking about those things and seeing what they do. There definitely have been times where I will use various resources. I'm a big fan for behavior issues of using childmind.org just to talk about parenting skills of, positive reinforcement or, kind of setting limits. And I think that even though the child may have, again, a little bit of a different perspective from their developmental trajectory, those skills can still be very useful and at least provides, I think, with parents, something that they can do, something they can work on. And again, it just brings a little more focus to the problem.
Great. So you already answered this with the Child Mind site, which I agree is a great site. But one of the other participants, Jen Snyder, asked if there's any particular books or toolkits or sort of resources for skill developments. Are there any other ones that are favorites of yours that you think would be good to share? We can also distribute this after the session to everybody's if you have a list as well.
We have a laundry list, and I don't know what it is because our autism resource specialist takes care of it. But that's a person that you could call. And each of the medical centers has an autism resource specialist, so that might be you'll get a more comprehensive answer. There's a lot of good stuff out there. What's the most appropriate depends a little bit on the family, of course. So, and the autism resource specialist can ferret that out, which resource sounds like the right resource for this family. So maybe that's a good resource, is to go to the resource specialist first.
I think the last question we have time for is melatonin. Jennifer Casper asked about melatonin, and particularly, I think, in relation to the case that Dr. Ruby had. Yeah. A problem that's near and dear to my heart. I do sleep hygiene training, I'm sure, with 30 or 50% of the families that I work with. It's rarely needed. I have definitely seen it jumpstart a better set of sleeping habits, so it has a role to play, but it really should not be needed over the long term. The issue is, how do you do the training? And there's a website that I built from my consultative work, which is called the IEP for Home, which I use. You could look at that if you're interested, but it's really, how do you train the parent to train the child? And there's a lot of resistance and confusion, I think, on the part of parents to do that training, because it's not that easy to do always. And really helping them through that training, I think, is the best therapeutic intervention you can offer. The melatonin sometimes does settle the kids successfully, and if you're lucky, they'll sleep through the night, but it's not designed to help the kids sleep through the night. And it doesn't take care of all of the sleep onset problems that kids have. Most commonly, it's a question of wanting to sleep with the parent, and the melatonin can't fix that problem. So as soon as the parents want the child to sleep independently, the melatonin no longer works as well. So it does have a role. It is safe. It is a good starting point just to, help the system reaccommodate if it ends up working, but it's not usually a good long-term solution. So I'm afraid, thank you, Eric. I'm afraid we're going to have to stop, but we've run out of time. It's wonderful that we've had so many great questions. And I just want to give a special thanks to our speakers, Dr. Van Hahn and Dr. Hannum, as well as special thanks to our audience. This was a really, really lively discussion, and we really appreciate everyone's attendance. Don't forget to fill out the survey, because we really need the feedback. And don't forget that the recording and the slides will be available on the website, mcpap.com. So thanks everybody for attending, and have a great rest of your day.